Back in the mid-1940s, as World War II came to an end, countries faced a troubling realization, where diseases like malaria, tuberculosis, and polio were ravaging populations just as aggressively as the war itself. It was clear that no single nation could tackle these threats alone, so on April 7, 1948, 61 countries came together to establish the World Health Organization. Headquartered in Geneva, Switzerland, the WHO marked a new era, one where health became a truly shared global responsibility. WHO's creation wasn't an overnight decision. It emerged from decades of global health crises. Take the 1918 influenza pandemic, for instance, which impacted about a third of the world's population, also killing about 50 million people. Later, during World War II, infectious diseases claimed nearly as many lives as the combat itself. Leaders then realized there's an urgent need for an international organization capable of coordinating responses to these health threats. The WHO was their answer, a global guardian for public health. From PHI Media, I'm Gordon Thane, and with me for a conversation is someone who's spent his career at the intersection of global health, policy, and diplomacy, Dr. Garry Aslanyan. You're listening to the Public Health Insight Podcast, your go-to space for all things public health and global health, from the Sustainable Development Goals to the social determinants of health, as well as interesting dialogues about the diverse career opportunities that exist in these fields. Remember to subscribe to the podcast and leave us a rating on Apple Podcasts and Spotify so other people like you can benefit from our content. Garry currently serves as the Manager of Partnerships and Global Engagement at TDR, a special program based at the WHO in Geneva, Switzerland. He deeply understands how decisions made globally ripple into communities everywhere. Garry also hosts the popular Global Health Matters podcast, bringing these global discussions to life. On top of that, he's an adjunct professor at the University of Toronto and the University of Ottawa, training future public health leaders. Garry joins this show to help demystify the WHO and talk about its origins, how it works, and why its work matters to all of us. Garry, welcome back to the Public Health Insight Podcast.
Hi, Gordon. How are you?
I'm not too bad. I'm particularly excited for this one because you are, I would say, the first returning guest that we have who is a podcaster themselves, and that doesn't happen very often. And what it does show is that there's a lot to talk about in the space of global health. I don't think we can run out of topics. And I think your podcast is also a culmination of the endless number of things that you could talk about on a global scale.
Oh, well, I'm glad to be here. I'm
awesome.
First for something, I guess, today. Yeah, that's good.
You're first for this, absolutely. Now, we're here to talk about the Framework Convention on Tobacco Control. But given that there's tentacles to the WHO, the World Health Organization, the WHO as an entity now is probably more visible, I would dare say, than in any time in history because of what happened 5 years ago and how it's shaped the global health landscape. What has come with that is a lot of misconceptions and myths about what the WHO is, what they do, and what they don't. So before we get started talking about some of the influential policies that the WHO helps to shape at the global level,
right?
Let's talk about what the WHO is and what it isn't.
Oh, well, in a very kind of concise manner, WHO is a specialized agency of United Nations, meaning that it falls under that category. So we are part of United Nations, but created as a technical health organization over 75 years ago. And it's a member state organization, meaning states are members and they come together to establish and then later to manage and really to guide the organization. So there is, I think, that number one myth that WHO is a thing on its own. And it's not, because every country that is a member owns WHO, both in terms of, people who work here come from all different member states, but also the World Health Assembly the ultimate place where a lot of the decisions are made and resolutions are made, and some of the things we're going to talk about today are made, are really, these decisions are made by all those 195 countries. So I think that's important because people think that the organization is kind of operating on its own, and it doesn't. And we also always say WHO is more in the news. Well, that's what we think now. If you really look at history, eradication of smallpox or some other things that happened in the last 75 years that WHO was mentioned in public, the whole thing about primary healthcare and Almada and primary healthcare conference at the height of the Cold War, these things happened before. We just weren't around.
Didn't have the social media to amplify some of the messaging too.
That clearly is different, yes.
Beyond meetings and resolutions, what exactly does the WHO do? Firstly, it establishes global health standards, things like guidelines for clean drinking water, food safety, and recommendations for vaccine schedules. When new diseases emerge, WHO coordinates international responses. Consider COVID-19. WHO organized global information sharing, supported vaccine research, and provided essential technical guidance. Crucially, WHO offers direct support to countries that may not have the resources or expertise to respond effectively on their own. At its core, the WHO is governed by 194 member states. Once a year, these countries gather to the World Health Assembly, the WHO's highest decision-making body, to set global health priorities. Throughout the year, a smaller group, called the Executive Board, made up of 34 health experts elected by member states, guides policy implementation. This structure ensures that decisions are not only political, but informed by scientific expertise and practical experience. One of the things that I'm seeing a lot being discussed now too is, what does it mean when something like the United States says we want to walk away from all of this? Like, in what way would it be beneficial for a country who maybe doesn't see itself aligned with WHO priorities to walk away? I know that's a contentious question, but what does it mean? You mentioned member states involved in shaping WHO, but when you don't agree with something, I'm not really sure how that quite works out from a global health perspective. What does that even mean to walk away or not be involved?
Well, not really walk away, but I mean, the Constitution allows for countries to join or to leave. So not every United Nations agency actually includes every single state. And in fact, another thing is, not every state always has been a member of United Nations.
Okay.
I'll give you an example. Switzerland, where a lot of United Nations things have happened in the first 50 years of United Nations and all of that, was not a member of United Nations until maybe 25, 30 years ago. And they felt they want to be neutral, and joining United Nations is going to break with neutrality or whatever reason they were giving themselves. So just to say that it's not really first time. Obviously, a country of its size and its role in public health, such as United States, that kind of intention to leave, let's leave it that way, because at the moment that's what all it is, because you can't just leave in one day. There's a process. It made the news, and it has its repercussions in terms of both what does that mean for global collaboration, what we're going to do, just because it's not a small country. Having said that, there isn't such a thing as a small or a big country when it comes to public health. And we've learned through COVID that you can be as big or as small, and your approaches to public health may be as effective or as not very effective. You may have been more prepared if you were a smaller country. With previous experience, like you have some countries in Africa who've had Ebola, another thing that was in the news a lot, and they had to prepare. So sometimes they were better prepared than some other countries. Resource reach, but they may not have had the planning. And it's not a criticism, just not everyone was prepared. So my take on this is that public health is in waves. And having worked in public health, I know things come and go.
But how does it work though? When you're a member, is there like a financial contribution that you make?
Yes.
How does that part work?
Right. So maybe this is another thing. So this is public information, obviously. So when you're a member, then you are assessed to have what is called assessed contribution. So obviously, when they come once a year or twice a year for executive board of the World Health Assembly, the member states say, oh, the organization should do this and that. And that's how you are going to spend the money we gave you. And that money the countries put together, they basically pool their funding, is the assessed contribution. That's a formula. There is a size of population, the GDP, and all of that. And that formula ends up having a certain number. And then each country, I mean, Canada included, and others, they would make that contribution. And some countries decide, important, to make additional contributions.
Okay.
And that's voluntary. And that might be focused on a specific area of work or specific gap. And that was clear during pandemic. There was much more needed to be done. So the assessed contributions weren't enough, so to say. Or there are emergencies. There is no shortage of conflicts and outbreaks and things that are happening in all over the world as we speak. And those require resources, and some countries come forward with additional resources. And interestingly, those are not always, we don't think of only rich countries.
Resources. Of course, none of WHO's vital work happens without resources. Its biennial budget, the budget that it makes every 2 years, is roughly about $6 billion US. Where does this money come from? Primarily from member states through assessed contributions, based on each country's population size and economic strength. Increasingly, voluntary contributions from governments and private entities help WHO further achieve their priorities. With such diverse funding comes complexity, so WHO regularly undergoes independent audits and evaluations, publicly reporting results to maintain transparency and accountability.
The program I work with and I interact with our smaller number of member states, and we have middle-income country contributions from countries that you may think on the surface that they are contributing. But we are working on something that is neglected, like neglected tropical diseases and infectious diseases of poverty, that these countries know more what it means to have. Hence, they want us to do more work. So voluntary contributions have become a bigger chunk of it, and hence they kind of make it a bit riskier because they're voluntary if they are not there. Hence, can the organization do everything that it wants to do or everything that the member states tell it to do or ask them to do? And that organization is spread all around the world with different country offices and regional offices. It's not an easy undertaking.
Exactly how does a global organization like WHO impact local communities? Where's the connection? Through its 6 regional offices covering the Americas, Europe, Africa, Southeast Asia, Eastern Mediterranean, and Western Pacific, the WHO collaborates closely with national governments and local health authorities. This structure ensures global strategies are adapted to local realities. For instance, during disease outbreaks, WHO regional offices mobilize supports tailored to local need, coordinate medical supply chains, and offer direct technical assistance to frontline health workers. It's this global to local connection that makes WHO's work genuinely impactful. You mentioned the World Health Assembly as a forum where member states come together to make decisions.
Yeah.
You mentioned too that there's no such thing as big and small because the pandemic was an example. Does that also follow through with the weighting in terms of voting on decisions? Is it 1-to-1, or the bigger the country, the higher influence they have? How does that part work?
No, it's 1-to-1. Everyone is equal. And usually that's the ministries of health and ministers of health or their representative or the secretary. I mean, not every country has a minister per se, but sometimes they're called health secretary or of the chief public health officer, or depending on the country, who represents them. They are the ones who are there. And there's one member, one vote. Most of things in public health are done by consensus. Hence, you have long negotiations sometimes. And that's some of the topics we're going to talk about. So obviously, if things are not always ready or easy to kind of seal, they are done in a bit of a separate process. But I mean, there's no difference. And that's the beauty of WHO in a way, that there are many other health organizations and initiatives where not everyone is included, or they are only for certain regions, or they are for certain types of countries. I'm not judging those things. I'm just saying that if you were to look at where does every country have a voice when it comes to health matters, there's only one and only. And you may have heard this before, but if WHO didn't exist, probably someone would have to propose it.
As this conversation comes to a close, it's worth reflecting on the journey we've taken, from WHO's creation after World War II, through its structure and operations, to its regional impact today. At its heart, WHO represents the powerful idea that health isn't just a national concern, but a shared global responsibility. Decisions made in Geneva, shaped by nearly every nation, ultimately impact your local health system, your community, and your daily life as a public health professional. Coming up next, we'll dive into something called the Framework Convention on Tobacco Control. It's a landmark WHO treaty designed to tackle the global tobacco crisis. We'll explore how this groundbreaking treaty was negotiated, the concessions made along the way, and how its legacy continues to influence tobacco policies across the globe today. That's next time on the Public Health Insight Podcast. This show was edited by me, Gordon Thane, with additional editing from LaShawn Benedict. Sound design and mixing by myself and LaShawn Benedict. The original music from The Music Room, composed by Tom Fox, licensed from Johnny Harris. The cover art designed for our show by LaShawn Benedict. The Public Health Insight Podcast is produced by PHI Media. Thank you for listening to the Public Health Insight Podcast, your go-to space for informative conversations, inspiring community action. If you enjoy our podcast, be sure to subscribe and leave us a rating on Apple Podcasts or Spotify. See you in the next one.